So thyroid's right here, just below the larynx, and it's like squishy glandular tissue. One thing to note before we go any further, do you guys remember from anatomy that glands are made of epithelial tissue? Do you remember that? And do you also know anything about the rate of cell division in epithelial tissue? Pretty fast. So does it make sense to you that glandular cancers are not that uncommon, right? Do you know anybody who's had thyroid cancer? Because I do. Yeah? Glandular epithelium has a predisposed high rate of cell division. So cancers in epithelial tissues are not that uncommon. So pituitary, pancreatic, thyroid, those occur. So just keep that in mind. Okay, so let's talk about the thyroid and thyroid hormones. So the hormones that come from the thyroid are collectively called thyroid hormones, but listen to this because this part's important. When people say thyroid hormones, they're only talking about these two. They are not talking about calcitonin, okay? So calcitonin is a hormone from the thyroid, but when people say thyroid hormones, they're talking about T3 and T4. Calcitonin is totally different chemistry, different feedback mechanism, different everything. So they always put that one out by itself. Okay, so when they are talking about thyroid hormones, however, they are talking about these two, T3 and T4. And yes, you have to know the long name because, of course, the long name has a bunch of information in it. So T3 is, let's break down the long name for it, triiodo, right? Because it requires 3 iodines to make it, okay? Thyronine, what does the INE tell you? It's an amine, okay? And it's from the thyroid. So 3 iodines from the thyroid and it's an amine, okay? There's also T4. T4 is tetraiodothyronine. And those two, your textbook goes into excruciating detail about the difference and the conversion mechanism between the two of them. I don't need you to know that biochemistry right now. T4 is more active than T3, but they tend to do similar things, although one not just as effectively, and they tend to have different levels in the bloodstream. You can lump them together. The other name, by the way, for T4 that is used relatively common clinically too, they either call it T4 or they call it thyroxine. So just know that name. Okay, I want you to know all of the names. Because the reason that I do this is not just to torture you, is because when you get into pathophysiology, I don't know which name they're going to know. But I don't want you to have absolutely no connection to what you've already learned, right? So the ones that I've seen used clinically or in other textbooks are the ones that I have you know, because I want you to be able to carry that information with you. By the way, in pathophysiology, if any of you guys are taking it next, take your endocrine table with you. My students kick ass in pathophys because endocrine is so hard, and a lot of people do it really lightly in physiology, but I do it pretty deep. And then when you get into pathophys, if you already understand how the feedback mechanism is supposed to work and they just break it in one place, you're like, oh, that's fine. I know what's going to happen. So hold on to your endocrine table and you can add more disorders to it when you get to patho. Okay, so the big picture about what these hormones do is that both of them increase the metabolic rate of almost all tissues, and both catabolic and anabolic processes. They basically just increase the rate at which your metabolism goes. And they affect almost every single tissue in the body. Now, during growth, during embryonic and fetal development, you're a big metabolism party, right? Okay. They're super duper important for brain development and for embryonic and fetal growth. You need less of them as you get to be an adult, but you do need them still. You still need them to support your metabolism. So when we start to break these in just a minute, what we will do is see what happens if you don't have enough during fetal development or don't have enough as an adult and how it manifests. Okay, so the chemical class of hormones, these are the only two that you learn that are lipid-soluble amines. Lipid-soluble amines. Iodine is required for the synthesis of both of them. In addition, before we actually do the feedback mechanism and then break the feedback mechanism with disorders, this is a hormone that is required before you can commit to growth. Let's see if this just makes conceptual sense. So growth is cell division and repair and protein synthesis, right? But does it make sense to you that your body actually checks for adequate levels of thyroid hormone, which means you have an adequate metabolism, before it commits to growth? Yes? So if you have a thyroid problem, you are going to have a growth problem. If you have a thyroid problem, you might have a healing problem. Yes? Okay, so go ahead.
I think people It should be thyroid problems to weight problems.
We'll talk about that. Just hold on to it for a second and hopefully it'll clarify itself for you. Okay, so let's talk about the feedback mechanism. So you now, with T3 and T4, have the capacity to do the entire feedback mechanism. I'm going to do this first one for you, but I'm going to have you help me with it. The entire feedback mechanism for thyroid hormone regulation. So thyroid, like all hormones, is like a Goldilocks hormone. If you have just the right amount, then you have just the right metabolism for your level of activity. If you have too much, it causes a disturbance. It can cause weight loss and sleeplessness and all those kinds of things. If you have too little, it can cause a disturbance. You're going to be super lethargic. You're going to start to gain weight, right? Does that make sense? Okay. So let's talk about how in a healthy person you get that Goldilocks level of thyroid hormone. So when you were telling the thyroid story, what organ do you start with long before the thyroid? Yeah, you start with the hypothalamus, right? And the hypothalamus secretes what hormone that's relevant to the thyroid story?
TRH.
Yeah, TRH. Do you know what TRH stands for? Thyrotropin releasing hormone. Okay. And then TRH goes where, guys? Anterior pituitary, Melody. I think you said that once before. Okay. And then the anterior pituitary secretes what relevant hormone? TSH. TSH goes where, guys? Thyroid. And the thyroid will respond by secreting these two classical thyroid hormones, T3 and T4. Now, the only thing I don't like about this figure, actually, there's two things I don't like, but the only thing I don't like here is that it just puts TH. That is not the abbreviation. It's actually T3 and T4, okay? So it secretes T3 and T4. Now, what we haven't done yet is look at the feedback mechanism and the why of the feedback mechanism. So let's just say we don't have to worry about numbers, but let's say this is T3 and T4 over time, and this is a healthy range for T3 and T4 over time. How do we keep it in the healthy range? Well, the feedback mechanism right here is going to be that whenever I have enough T3 and T4, it can feed back into the system. Now, the hypothalamus, guys, is part of the brain, and it's protected by the blood-brain barrier. But what about this chemical, these chemicals? Allow them to ignore the blood-brain barrier. They're lipid-soluble, exactly. So lipid-soluble stuff goes wherever the hell it wants, anytime it wants. So these, as they start to increase, will have a negative feedback inhibition on hypothalamus secretion of TRH. Does that make sense to you? Yes? And these, as they start to increase, will also, just so the feedback is faster, feedback to the anterior pituitary, right? Because you can feedback to the anterior pituitary, it's not brain. So with this in mind, what I want you to see is that what will happen as your T3 and T4 start to increase? Well, what's going to happen is they're going to decrease TRH and TSH secretion, which will decrease them again, right? So what's going to happen is it's going to start to go down, right? And as this goes down, right, you're no longer inhibiting those two, so it starts to come back up, right? So this is in a healthy person, what's going to happen is you're going to stay pretty damn close to the ideal range for thyroid hormone all of the time. Does that make sense? Because of negative feedback inhibition, okay? And that's what this is doing for you. Now, FYI, you are going to have to do these feedback loops for almost every single hormone. The only one I think that I don't make you do it for is aldosterone, because it's got like 5 different feedback mechanisms. It's a pain in the ass. So I'm going to do the first few for you, and then I'll like leave some and see if you can do them, okay? So do you see that this is basically just an example of negative feedback inhibition? We could have told it during the first set of material that we did, right? But now you've got specific information about it. Okay, so now let's break it, and let's see what happens with the loop if we break it, okay? So first thing is let's do it in an infancy and fetal development and see what occurs. Okay, so this one is a terrible story. So if you have, for whatever reason, inadequate levels of T3 and T4, what is going to happen is you are going to have improper brain development and also growth in the fetus. And you get one shot at putting a fetal brain together. And it starts 4-ish weeks post-implantation, and it continues the entire pregnancy. So This means that if a woman has a thyroid disorder and is not treated during her pregnancy, then it is going to impact the development of the brain. Now, if she is treated during her pregnancy, she can have a perfectly healthy pregnancy. It's one of the reasons that you need prenatal care, because thyroid disorders aren't that uncommon. And you can totally have a healthy pregnancy, but only if you are watching your thyroid levels, okay? So if a woman was untreated and had hypothyroidism during her pregnancy, what would happen is the baby would have what's called congenital hypothyroidism, also called cretinism, and it's permanent damage. This is a really old historical drawing of cretinism. You'll see the goiters, you'll see the really, really small stature, and what you can't see in the picture is that they have permanent brain damage, developmental problems. So this is a more current picture of a baby with congenital hypothyroidism, and it's a little difficult to see what's going on, but this baby has brain development issues that are never going to reverse. In addition, the loss of thyroid and also growth hormone impacts the hard tissues, cartilage and bone, more than the soft tissues. So the soft tissues tend to grow more. So you got this protruding tongue, this protruding abdomen, and this little inguinal hernia that you can see there. And you can see the protruding tongue there as well. So this is called congenital hypothyroidism or cretinism. They don't use cretinism anymore, obviously. It's not very politically correct. But when you look up information historically, that's what it was referred to as. And sometimes these babies don't live past infancy. And even if they do, they're going to have severe, severe mental delays. Okay, so as an adult, of course, your brain is already developed, right? You are not going to have the dramatic brain development issues that you had before, but you are going to have some symptoms. So let's predict symptoms of too low a thyroid hormone in an adult. Too low. Hypothyroidism. Lethargy, exhausted, both mentally and physically exhausted. And what else? Weight gain. A lot of sleep disturbances. You sleep too much. You have a little trouble getting up. You can't do all of those kinds of things. So this is a woman, I don't know why she's so sassy with thyroid disorders, but she's like, I'm still amazing, guys. So you have lots and lots of things. Enlarged thyroid gland, a lot of times what happens with thyroid disorders is that your thyroid gland will try to compensate by going through cell division, and you'll get a goiter associated with it. Please note that even in this historical picture, they had goiters associated with it. Your thyroid is trying to compensate, and it's actually mitotic tissue, so it will try to make more for you. Okay, so your heartbeat's going to be slower. You usually got some weight gain and constipation because of reduced metabolism in the smooth muscle of your digestive tract. Lots of issues. A lot of times infertility is associated with it, depression. All of those things are associated with hypothyroidism. Hypothyroidism is usually autoimmune, meaning that for some reason your immune system makes a mistake and starts to destroy your thyroid gland. All autoimmune diseases are more common in women than in men. Hypothyroidism also... there's a suite of symptoms associated with hypothyroidism. There's like 20 symptoms that could be associated with hypothyroidism. And every few years, they say if you have X number of these symptoms, then you will be diagnosed with Hashimoto's disease. So Hashimoto's disease is hypothyroidism with large numbers of symptoms. Can you be hypothyroid and not diagnosed with Hashimoto's? Yeah. So Hashimoto's is just this collection of symptoms, right? Okay, but you can be hypothyroid without actually being diagnosed with Hashimoto's. So what do you do for treating a hypothyroid disorder? What do they do?
I take medication. Yeah,
you just add the thyroid medication back, right? So you add it back, and it's lipid soluble, so you can take it orally, right? Synthroid is sometimes what they use. Now, the only issue here is that in a healthy person who does not have a thyroid disorder, this is going on minute to minute, hour to hour, right? This feedback to adjust. In a person who has hypothyroidism, then what they do is they assess your thyroid levels, they give you a diagnosis, then they do their best guess of what level of Synthroid or thyroid supplement would help, and sometimes they give iodine too. Do they give iodine too to you? Interesting. So sometimes they give iodine, sometimes they give thyroid medication. But then they don't test it every moment, right? And they don't test it every day. Sometimes every 2 weeks at the beginning, every few months later on. And so the feedback mechanism is nowhere near as finely tuned. So what happens sometimes is that you get a little too much and then you get some symptoms of hyperthyroidism. Or you get a little too little and you're still having weight gain and you're still exhausted. So since your feedback mechanism is really, really on point, you're never going to quite get that with medication. You're going to do your very best. But the problem also exists that if you give too much, you'll downregulate your thyroid receptors. And if you give too little, you'll upregulate them. So it takes some finesse to get that level right. Did it take a while to get the level right for you? Yeah?
Yeah.
Months? A few months?
Still working on it.
Oh, still working on it. Still working on it. Yeah. So this is autoimmune, usually. Okay, so let's talk about hyperthyroidism. And this one's a really interesting one. So hyperthyroidism is when you're secreting too much of it. It can be because of a tumor. If it was a benign tumor, they might not immediately take it out, right? If it was metastatic, if it was cancerous, they would take it out. So what happens, you get all kinds of weird stuff like hair disturbances and stuff, but you get your body temperatures are usually really high. You have a hard time cooling down. Here, a lot of times you have a hard time warming up. But with hyperthyroidism, you've got a rapid heartbeat, difficulty sleeping, and the difficulty sleeping comes with its own suite of problems because when you have sleep disturbances, it tends to cause problems with stress hormones and all that kind of stuff. Infertility is also associated, weight loss, frequent bowel movements, all of those things. Now, if you have X number of these symptoms and X number changes from year to year, then you could be diagnosed with Graves' disease. Okay, Graves' disease is just when you have a certain number of the symptoms of hyperthyroidism. And associated with Graves' disease could also be goiter, because sometimes if you have a goiter, like a benign tumor, it actually causes Graves' disease, right? Does that make sense? So the goiter can be associated with either hyper or hypo. And then the other thing that's associated with Graves' disease is exophthalmos. For some reason, I don't understand this one, honestly. Although you tend to lose weight with Graves' disease, the fat pads, the orbital fat pads behind your eyes, build up more fat, and you have this exophthalmos, is what it's called, when your eyes progress. This is pre-treatment, and this is post-treatment with this woman with Graves' disease. And sometimes it's so bad that you can't actually close your eyelids. So your eyes really, really dry out with exophthalmos. So this is pre and post-treatment. I don't know if she had a tumor or if she was just treated with medication. What do you think is harder to treat, a hyposecretion or a hypersecretion?
I think hyper.
Hyper is way harder to treat. It's a little difficult. We don't always know what antagonists would work, right? So unless it's a tumor that you know that you can take out, the treatment is a little bit more difficult to actually make that work. So let me teach you two different causes of Graves' disease. Okay, so if we have Graves' disease, what we're going to have is we're going to have too much of this that's produced, yes? Now, a common source of that is a tumor here or sometimes a tumor here. Either one could cause it, right? If you're over-secreting TSH, then you'll over-secrete T3 and T4. Or if you just have a thyroid tumor, you'll over-secrete T3 and T4. Now, here's a weird one. Usually, autoimmune disorders cause hyposecretions, right? Because an autoimmune, like your immune system would destroy something and then it couldn't make what it was supposed to make. This is a weird situation in which this is an autoimmune disease that causes hypersecretion of T3 and T4. Because what happens is in this situation, I got exposed to some kind of pathogen. I don't know what, because they don't know what one is associated with this one. And I started making an antibody. And antibodies are proteins, peptides, yeah? And this peptide just happens to be a TSH agonist. Yes? And so what's going to happen is it's going to continually mimic TSH at the thyroid gland, and then you're going to do what with T3 and T4? You're going to continue to produce T3 and T4. How would you tell if it was the autoimmune form of hyperthyroidism? All you'd have to do is measure this level, right? And then measure those two. If it was autoimmune hyperthyroidism, you've got high levels of T3 and T4, but what about your levels of TRH and real TSH? What are those going to be? Low. Does that make sense to you? That tells you that something is actually interrupting right here. It's broken right there, right? So that's autoimmune hyperthyroidism, which is the most common cause of Graves' disease, actually. Autoimmune hyperthyroidism. That make sense to you guys? Okay. So they actually have the capacity now if you go to an endocrinologist, not if you go to just your GP. They actually have the capacity to measure for this antibody. Even though it looks just like TSH, you can actually measure for it specifically. They still don't know what pathogen causes this disorder that quick. Go ahead.
How do you have your thyroid tested? Like, do you run any?
Well, if you want it, the first level, they could test at any general practitioner. And they also usually test at your OBGYN, especially if you either have been pregnant or want to be pregnant. They did test you. Do you have kids? I can't remember if you do. They do test you when you get pregnant. They test for TSH and T3 and T4. They don't ever test for this one. It's hard to detect because it's in really low concentration. So you can have almost any doctor test for it. But yeah, it's just a blood test. Just blood test. That's all. And when I go in, I like anything that the insurance will pay for, I have them test for. I'm like, just test for all of it, man. I want to know my vitamin D levels. I want to know everything. You're already poking me, right? Might as well. Okay. Also, I'm just curious. Like, I just want to know what's going on inside. Okay, so that's hyperthyroidism, Graves' disease. So the symptoms of thyroid hormone disorders are goiters, as we mentioned. This is a minor goiter. This is what they're generally going to look like. This is an iodine deficiency goiter caused by living in an area of the world. Usually high elevations with lots of rainfall because iodine is water soluble. And if you're high elevation, lots of rainfall, it just continues being carried down, for instance, the mountain. And if you don't have a source of iodine other than that, iodine is usually in salt water, especially saltwater foods, fresh water. If you don't have another source, then what happens is you can have massive iodine deficiency problems. Now, it's not a big problem for us any longer, even though in Utah, we don't eat a whole hell of a lot of fish, do we? No fish, no spice in Utah. My mother-in-law thinks salt and pepper are literally the only spices that exist. It is tragic to me. Go ahead.
How do they get rid of the goiter?
Okay, so in this situation, if this were an iodine deficiency goiter, you just give iodine to this person and then it will go away. In this situation, you can give iodine, but she's still going to have all that tissue, right? At this point, you're probably going to have some kind of surgery if you ever want it to look normal at all. But this is not something that generally happens. This is because of a lack of iodine and also no access to medical care. And this is not something that generally is going to happen in like these situations where you have access to medical care. It's not going to happen. But this was just an iodine deficiency tumor or iodine deficiency goiter. That's all it was. Just add it back. So a lot of times with that situation, they just add it back and then the goiter will go away. Okay, so goiter, exophthalmos, and heat and cold intolerance. Generally, if you're hypo, you're usually really cold and can't get warm. And if you're hyper, you're usually really hot and can't get cool. Okay? All right, so now the question I ask you right here is just, can you do this? Which hypophysiotropic hormone and which anterior pituitary hormone ultimately control the secretion of T3 and T4, okay? And that is that right there. And you know all of it now, okay? Make absolutely freaking sure before your endocrine test that you can do everything related to thyroid. Because if I can't come up with a question, I always do a thyroid question. Because like it's like the easiest feedback loop and you're going to run into it clinically. It's important, right? It's going to be a big one. Okay, now the thyroid also secretes a different hormone, but I want you to make a break in your head. This hormone is called calcitonin. It comes from the thyroid and it doesn't have a damn thing to do with this story. Okay, so when people say thyroid hormones, they are talking about T3 and T4. When people are talking about calcitonin, they name it by name. Calcitonin. It's even made from different cells in the thyroid. Okay, so let's talk about calcitonin. It has a whole different feedback mechanism. Calcitonin is responsible for lowering your blood calcium levels. Calcium is another Goldilocks thing that you need in proper amount. Too much, you'll clot improperly. Too little, you get no cardiac muscle contraction and no neurotransmission. So we have to really tightly constrain the calcium levels. So the way that I remember what calcitonin does is calcitonin tones down blood calcium. Okay, so what do you guys predict? C says calcitonin would be released in response to what? High or low blood plasma calcium levels? Yes. So the trigger for calcitonin release is high calcium and it's blood. Okay. So now we are going to think through this together. High calcium is detected by the thyroid. and the different cells in the thyroid. And the thyroid responds by secreting what? Calcitonin. And I'm going to tell you the major target, and then you guys are going to help me figure out the minor targets. Okay? The major target is the place in your body that is your calcium bank. Where's your calcium bank? Bones, exactly. And in this situation, should I make a deposit into the calcium bank or a withdrawal? I need to make a deposit, right? I've got too much calcium. Does that make sense? So what I'm going to do is I am specifically going to go to bone, but a specific cell that you should have learned in anatomy called osteoclasts. Yes? And what I'm going to do is osteoclasts are responsible for breaking down bone mass and dumping the calcium and phosphorus into the bloodstream. What should I do to the activity of the osteoclast here? Increase it or decrease it? Decrease it. I need to decrease osteoclast activity. And if I decrease osteoclast activity, you guys remember that osteoblasts and osteoclast are usually balanced. If I decrease osteoclast activity, then the net effect is that I, comparatively increase osteoblast activity, right? Does that make sense? So what is this going to do to your calcium level? It's going to decrease your blood calcium level. And what is the feedback mechanism here? This time it's not a hormone that feeds back. This time it is simply a new level of calcium that feeds back. And what do you think it's going to tell the thyroid to do?
Stop.
Yeah, stop secreting calcitonin. Does that make sense? Okay, that's how that works. Okay, so this is the major target, but I want you to use that rule that we used before. So the rule that we used before was, if a hormone has more than one target, it's never going to counteract what it did at one with what it does at the other. So I'm going to give you two more targets. I'm going to see if you guys can figure out what it does. This is not a memorization thing. This you have to memorize. It's the major target, major function. Okay? I'm going to give you two more targets and see if you can figure out what you would do here that would be consistent. Any idea what you could do at the kidney that would be consistent with this functionality? What could you do at the kidney that would help with that? Huh?
Decrease its activity, so it doesn't.
Not decrease the kidney activity. Increase calcium excretion at the kidney, right? Pee out more calcium. Yes, that makes sense? Okay. How about the intestine? What can I do at the intestine that would be consistent? Decrease absorption. Yes, decrease absorption. All of those things happen and they're all consistent, right? So again, what I told you guys last time is that ideally with physiology, what you get is an understanding of the big picture goal, and you say, okay, I've memorized this, but I know what is consistent, right? I know that if I was going to do something at the kidney, it would have to be consistent with this. I know that if I was going to do something at the intestine, it would have to be consistent. That makes sense? And it does have those three targets, but this one's the major one. Okay? Okay. Now, one more time, just to make sure you know. Calcitonin is not regulated by the TRH, TSH, T3, T4 feedback loop. Totally different regulation mechanism. Okay? All right. So you need to fill in the columns for all of the thyroid hormones, okay? What is the chemical class of calcitonin? It's peptide, yeah. Okay, so after we did calcitonin, parathyroid glands are going to be easy because they do the opposite of what calcitonin did. Okay, so let's talk about the parathyroid glands. Now, first off, do you know where your parathyroid glands are? They're on the back of the thyroid. Yeah, so they look like two little pairs of nipples. And before we knew much about histology, they thought they were just part of the thyroid. And so if they cut off the thyroid, they would cut those off too and get you more unintended consequences. So the parathyroid are on the back of the thyroid. They only secrete one hormone, and it's easy because it's just parathyroid hormone. That's it. That's what it's called. Okay, so this is basically the opposite of the hormone that we just learned. So it targets bone and kidney tissue to increase circulating blood calcium and phosphate levels, which means this hormone's action opposes the action of what hormone from what gland? Calcitonin from the thyroid gland. Okay, so you guys tell me, if its job is to increase circulating blood calcium levels, it's probably released in response to what? Low or high? Low. Okay, so let's tell this story. Ready? So, in response to low calcium in the blood, pen. It's detected at the parathyroid. Parathyroid secretes PTH. PTH goes to the same major target. What's the major target? Bone. And specifically the same cells. Only this time you're going to do something different to them. What are you going to do to the osteoclast this time? You're going to increase the activity of the osteoclast, and what's that going to do to your blood calcium? Yeah, increase blood calcium. And what's the feedback? Yeah, it's net. Well, no, it's negative. Calcium feeds back. It was too low. Now you've increased it. And as you increase it, right, feeds back new data, and the parathyroid gland will do what to the PTH secretion? Decrease PTH secretion. Does that make sense? Okay. Now, the other major target is the kidney. I bet you can figure out what it would do with the kidney. What's the other major target? Kidney. What do you think it does? If this one increases kidney secretion to decrease blood calcium, what does this one do? Decreases kidney excretion, so you hold on to your blood calcium. Does that make sense? And apparently it doesn't have a major target on the intestine. Doesn't seem to be able to impact calcium absorption very much. Okay, so do you see those two are just pretty much parallel to one another? Are you starting to think that you could do this kind of thing on your own? Right? You totally can. Well, I'm not going to do all of them for you. I'll do the first ones, and then I'm going to have you guys do some. Okay. So the PTH is a peptide. So tell me the major target for PTH. Bone, specifically osteoclasts and bone, right? Give me a blurb, a little snapshot of the function of PTH. What's it trying to do? Increase blood calcium. Yes? So if you looked over time at what your calcium did, and you had your Goldilocks level that you wanted to keep, what would happen, guys, is if I drink a milkshake, yes, and my blood calcium goes up, I secrete calcitonin. Oops, spelled it totally wrong. There's a bunch of letters in there. That ain't the right one. And then you start going down and you don't have enough calcium, you secrete PTH. If this is working properly in you, then you just basically keep your calcium in the Goldilocks level, right? Okay? Okay. Any questions? Everybody good? Okay. So now we are going to move to adrenal glands. And adrenal glands are super duper interesting. The terminology is a little sticky until I separate it out for you. So pay attention to the terminology because you actually have to get this in order to understand questions about it. Okay, so let's do adrenal glands. And first we have to acknowledge that the adrenal glands are really physiologically two different structures. There is the adrenal cortex on the outside, yeah, and the adrenal medulla on the inside. You already know the hormones that are released from one of those. Which? Cortex or medulla? Yeah, you know the adrenal medulla hormones, right? You don't know the cortex hormones yet. We're going to do cortex first, and then we'll come back and do medulla, okay? All right, so the adrenal cortex is around the outside. It is not this big. You can tell that this person, have you ever seen how small the adrenal glands are? Do you want to know something historically weird about this, that the reason that they're always drawn so big and so improperly big? A little bit of historical inaccuracy. So when they first started doing human cadaver dissections for med school, for instance, the only populations that they had access to were indigent populations and criminals who were hanged, for instance, because people didn't do body donation. historically speaking. So this is even before the United States was a country. And so what they found is over and over and over again, the adrenal gland was pretty large, was like that large. Because what we will see is that the adrenal gland is really, really related to stress physiology. And if you have a life of stress, of starvation, of violence, of sickness, which is more associated with poverty and indigent situations, then your adrenal glands are enormous. And when people first started doing body donations from middle class and upper class families, they thought that those bodies had adrenal malformations, like their adrenal glands were entirely too tiny, because the population that they were comparing them to were the indigent populations. So all of these pictures are just like this little historical anachronism that just keeps being perpetuated in textbooks. So interesting. Go ahead.
Do people who have anxiety or hallucinations and they don't get treatment for them, do they have bigger adrenal glands as well?
It depends on whether it actually involves these adrenal hormones that we talked about. You can have anxiety that is primarily related to brain functionality, but if your hypothalamus starts activating your adrenal gland, then you will have an increased adrenal gland. So we'll talk about the whole last part of this set of notes is stress physiology, which I have been reading about a ton for the last 10 years. And so I will tell you my best information that I have on this, which I just read the most recent journal articles just a couple months ago. So I'll tell you what I know, and we can start doing that story. We can talk about PTSD and chronic stress and all that kind of stuff. It's at the end here. Okay, so let's do the adrenal cortex first. Cortex is the outer portion. All hormones from the adrenal cortex are steroids. Tell me what I mean when I say they're steroids. Lipid-soluble, derived from cholesterol, yes. They're all derived from cholesterol. They're all lipid-soluble. That's what they have in common with one another. Remember that we saw all of these steroids here. So specifically, let's talk. The ones from the adrenal glands, so steroids is a general term, yes? But the ones from the adrenal glands we call corticosteroids, or sometimes adrenocorticoids. I'm not used to using that term. I call them corticosteroids. If you're British, you call them corticosteroids. If you ever listen to a YouTube, they're not saying it wrong, as usual, we are. But corticosteroids, or if you're from Texas, you say corticosteroids. Corticosteroids are steroids from the adrenal cortex, and they are subdivided into 3 categories. And you need to know all of these names because clinically they use these terms over and over again. Okay, so corticosteroids come from the adrenal cortex. They're steroids, and they're divided into 3 categories by what they regulate. Salt, sugar, sex. They regulate salt, sugar, sex. So I'm going to give you the name of the category, and then you're going to tell me what it regulates. Okay? First ones are called the glucocorticoids. What do those regulate? Sugar. The next ones are called the mineral corticoids. What do those regulate? Salt. And the last ones are called the gonadotropins. What do those regulate? Sex. Okay, so when you are filling in your table, you not only have to know that everything that comes from the adrenal cortex is a corticosteroid, you also have to know which category it fits into, and then I'm going to give you 1 or 2 examples of each one. Okay, specific hormones that are examples of each one. Okay, so let's do mineral corticoids first. There's only one of these that you have to know, and it's called aldosterone. Comes from the adrenal cortex. This is one of the few that you don't have to do a feedback mechanism for because it's got like 4 or maybe 5 different feedback mechanisms. It's just too hard. I'll give you a simplified feedback mechanism later, but I don't usually ask you about feedback on this one. So here's what this one does. It is, listen, and then I'll give you a visual on it. It's primarily responsible for controlling your sodium and potassium levels in your bloodstream by targeting your kidneys. Isn't that a good place that you could do that? You could decide how much to keep versus how much to get rid of. So sodium, potassium, and also the H+ ion, hydrogen ion. And here's how it does it. And by the way, this one comes back at you multiple times because it impacts the kidney, so we talk about it in the urinary system. But we will see that it also has an impact on blood pressure, so we talk about it in cardiovascular. So if you can get it now, your life will be a little more peaceful. Okay, so it's going to target the kidney. And the kidney actually, what the kidney does is exchange things between the blood and the urine, right? Isn't that generally what the kidney does? Okay. Okay, and so specifically what aldosterone does at the kidney is this. It causes you to retain sodium in the bloodstream. Yeah? What will that do to your blood pressure, by the way?
Increase.
Yeah, increase it. Okay, so that's the indirect impact on your blood pressure. That's why you talk about it in cardiovascular system. But it does it at the expense of another positive ion. And the other positive ion is either potassium or H+. And one of the reasons I don't have you learn the feedback mechanism for it is because the trigger for its release could be sodium level, could be potassium level, could be acidity in the bloodstream, or water conservation. And that's freaking hard to memorize all four of those. So let's just say that it causes sodium retention and potassium or H+ excretion. Is that okay? So it's regulating those levels. Okay. So we'll come back to this one, but this is the basics of what you need to know about it. Okay, so now we get to one of my favorite hormones, but also one that I have really, really been trying to understand for probably a decade. This is, to me, the most complicated hormone. I'm not going to have you try to grasp all of the complexity, but hopefully I'll get you a big picture understanding of what these do. So these are the glucocorticoids, these guys right here. And they're primarily regulating sugar. It's a little more than that. And there are two of them. The one that you hear about most often is cortisol, and the other one is corticosterone. This one you run into clinically. I used to only teach this one, but this one you run into clinically. By the way, if you run into something that starts with corta, it's probably one of these, or an agonist for one of those. Okay, so I want to talk about these. I want you to get a big picture understanding. I really want you to have the big picture of these before you get lost in the details. So first thing is, your textbook for some reason took out this image. It was in a prior version, so I'll post it for you. So I want to talk about why you release these and what they're important for. So we're going to concentrate on circadian rhythms. And I'm going to show you this in just a second, but let me just tell you a little story first and to give you the importance of these glucocorticoids. Okay, so the story is this. Even when you are sleeping and can't or won't, or if you're ill or something and you can't or won't take in nutrients, the nutrient requirements of your brain do not stop, right? Your brain has almost a constant metabolic rate despite the fact that you're not taking in nutrients. Does that make sense to you? That means there must be a mechanism of making sure that you have adequate circulating nutrient levels to keep you alive. Yes? Okay. And that is cortisol. So cortisol is absolutely necessary for keeping you alive. There are times in which you can't or won't eat, but you are not going to die. So you have the trigger to basically use up all of your stores to make sure you get through this. And this is super duper important. So think about an 8-hour sleep. But then think about you being ill, and instead of sleeping 8 hours, you sleep 16. Do you still stay alive? You do. Why? Because you are secreting this cortisol to actually increase your circulating nutrient levels to keep you alive until you can or will eat again. This is also really important in starvation conditions. It's really important in illness. It's really important in the first trimester of pregnancy. Is there anybody but me who could not eat a damn thing the first trimester of pregnancy? Is there any other moms here? I know you're a mom. Yeah? Just threw up my guts. I don't even know how I stayed alive. Just like hair falling out, throwing up my guts. I couldn't even drink water. So what keeps you alive? What keeps you alive during those times is cortisol. And cortisol pretty much increases your circulating nutrient levels by any means necessary. It also keeps you alive during illness. Right? Go ahead.
I had a patient yesterday that was asking why we're testing his blood sugar when he's not for the headache.
Oh, yeah.
He's sick.
Because he's sick, and cortisol will actually really jack up your sugar. So let's see what it does and see how it actually jacks up your sugar. And also start to figure out how chronic cortisol secretion can cause type 2 diabetes. Go ahead.
Adding to this, another time when I have patients that asking me the same thing, why they test my blood sugar not diabetic, is because they're giving me steroids.
Oh yeah, steroids. We'll talk about steroids in just a second too. So steroids are fascinating. So let's talk about the normal use, and then we'll talk about sickness and steroids and all of that kind of stuff. So here's what's happening in a normal, healthy person. So let's talk about this normal, healthy person. The normal, healthy reason to secrete your glucocorticoids is because of circadian rhythms, right? So your circadian rhythms tell you when you are not going to be eating for a little while. So follow this story with me, okay? So your circadian rhythms tell your hypothalamus when it's sleepy time, right? And then your hypothalamus secretes CRH. You guys with me? And then your anterior pituitary secretes ACTH. And then your adrenal cortex secretes cortisol. And what cortisol will do is it will keep your circulating nutrients high enough to keep you alive, right? Not outrageously high enough to keep you alive by any means necessary. The thing that they didn't put in here is the first thing that it's going to do is, of course, cause glycogenolysis of whatever stored glycogen you had in your liver, right? Right? Does that make sense? So you're going to cause glycogenolysis and dump that sugar into your bloodstream to keep your brain alive while you're sleeping. What happens after you run out of the glycogen that was stored in your liver? What happens after you run out of the glycogen in your, that was stored in your liver is you'll do the next one, which is gluconeogenesis. Do you remember what gluconeogenesis is? It's making glucose from what? Where do you get it? Nope. It's making glucose from something. Amino acids, exactly. If you have circulating amino acids, it'll use those, but if it doesn't, you don't have circulating amino acids, you'll start to break down proteins, right? Now, this isn't super problematic because most of us have glycogen stores and amino acid stores to get us through the night, right? But, for instance, if you're sick and you sleep for 16 hours, are you probably going to lose a little weight? Yeah, you probably are. You're probably going to lose a little muscle mass during those times in which you're doing that. So it increases protein breakdown so that you can do gluconeogenesis. It's also going to decrease protein synthesis because you cannot afford anabolic processes right then, right? So you're going to build a whole hell of a lot of muscle right then. And then, of course, other tissues can use fat. So you'll also cause lipolysis and motivate the fatty acids into your bloodstream. Does that make sense? So this is what it's doing, right, to keep you alive. And then in addition, if you do this for a decent amount of time, it's also going to depress the activities of non-essential functionality, right? It's going to say, hey, we're low on nutrients. Let's not do a whole lot of reproductive function. And if you secrete it for a while, it actually depresses your immune system because we don't think about our immune system being non-essential. But I want you to think about essential as getting you through the next 48 hours. Immune system is planning for the future, right? And if we ain't getting through the next 48 hours, we do not care what's happening 6 months from now, right? So especially think reproductive and immune system, it will actually depress those somewhat. It's not dramatic overnight, but if you did it for days on end, it actually causes that. Okay, so everybody okay with that? So the metabolic functions, the big picture metabolic functions for all of us is it raises nutrient levels in the bloodstream for whenever you can't or won't eat. Yes? Keeps them adequate, and it does it at the expense of non-essential tissues, right? And as soon as you start running down, it's going to start breaking down your own proteins. So this is not an anabolic steroid. This is a catabolic steroid. Catabolic steroid, right? It's doing catabolism and dumping stuff into your bloodstream. So now, the other functions that we need to understand is that if you do this long term, it's going to have an immune function effect, right? So if you constantly secrete cortisol, and we'll talk about some reasons that you could constantly secrete cortisol, it's going to suppress your immune function because it's non-essential. And what happens is the depressing of the immune function sometimes can be something that we're going to do clinically on purpose. When you administer it in large amounts, and we actually use this clinically, prednisone is one of these. It's an agonist for your corticosteroids. Okay, one of those is depressing a specific portion of the immune system to keep you alive. It's a really, really powerful anti-inflammatory. Yeah. And it's because inflammation is the first step of healing, right? So you are actually suppressing immune function this time on purpose, which seems like a poorly thought out plan, except if you have a closed head wound, right? Or if you have inflammatory condition that is life-threatening, right? Then the inflammation is the issue that you need to deal with there. But let's talk about why the hell using prednisone is both really effective and also has boatloads of side effects associated with it. Just side effects everywhere. Why? Well, because let's think about this. Let's just say I have a closed head wound, so it's a simple injury, right? It's just like inflammation that I have to deal with there. What I have is a paracrine activity going on right here, right? It's paracrine, right? But it's so incredibly life-threatening that I am going to pull out the big guns and use a hormone agonist to treat it. But the hormone agonist does not just treat there, it treats all of the functionality of the hormones, yes? And so it will increase your circulating glucose levels, right? It will start to do breakdown of proteins. It has all kinds of effects on your brain because it's lipid soluble. It makes you act like a total turd head. Prednisone really changes people's personalities. And why would it be worth it? Well, because in that moment, the alternative is death, right? So, but it is a hormone that is actually treating a paracrine activity. And the only reason we use it is because we don't have anything that is anywhere near as effective as an anti-inflammatory as this one. Does that make sense? So what kinds of symptoms do you see with people who have been on steroids for a decent amount of time? Any idea? Any idea? Yeah, it affects their behavior, causes anger issues. Tends to cause weight gain, tends to cause water retention because it also jacks with your aldosterone. We'll talk about that. Water retention, behavior changes, loss of muscle mass, all of that kind of stuff starts to happen associated with prednisone. So generally speaking, unless you're in a life-threatening condition, if they put you on prednisone or a corticosterone agonist, they're going to put you on as short a course as they possibly can and then take you off. And then if you need another short course later, they'll put you on as short a course as they possibly can and then take you off, right? So they don't keep you on it long if they can avoid it. So now, last thing to talk about with this one is something that we're going to talk about in a lot of detail. Go ahead.
Is it the aldosterone that gives you like heart arrhythmia when you take prednisone?
Yeah, because it screws up your potassium concentration.
Volume, like,
Yeah, so let me just show you that real quick because we're going to talk about it in just a minute. But can you see why if you... Where the hell's that picture? I lost it. Where's my hormone? There it is. Okay, this picture will show you why if you mess with your glucocorticoids, it'll cause aldosterone problems. Do you see? Because corticosterone is the precursor to aldosterone. So if you have a glucocorticoid problem, you're going to have an aldosterone problem. If you have an aldosterone problem, you screw up your potassium concentration, which can cause cardiac arrhythmias. That make sense?
what about like a water pill? Because that messes with aldosterone too.
Some of them. We will have to wait until we get to the urinary system to do water pills. Those are interesting. They can actually cause those problems too. There are different kinds of those. Does that make sense? Okay. All right. So now I want to talk about stress function just a little bit. Okay. We are going to do stress function in more detail later, but I want to tell you that there is one other trigger that dependably causes cortisol release, and that is stress. Okay. So now, I want to redefine stress. I want to do 1600 stress and then 2017 stress, okay? Let's go back a little further than that. Let's go back 1200 BC stress. So this stress mechanism was evolved when our stresses were different than they are now. So stress in 1200 BC probably had something more to do with starvation or disease or injury, right? Probably was not just a bad marriage, right? Or financial problems, right? Like your crops failed, your kids are starving, you're starving, you've got a disease, you can't get over it. And I want you to see how effective this cortisol mechanism would be for treating that stress. It could be long-term, but it was long-term but acute, because either it was going to end, like the disease was going to end or you were going to die, right? Starvation was going to end or you were going to die, right? But it didn't generally go on for decades. You guys with me? It went on for what seemed like a long time, but definitely had an end. And so can you see that this would be really an effective mechanism of dealing with that? So what we're going to do is you're going to decrease all non-essential tissues, right? Okay, to try to get you through, to try to keep you alive until you get over the disease. And then you are going to dump what's necessary into your bloodstream to keep your essential tissues alive, right? And it's going to be costly, but if it gets you through, then it's a good bargain. Does that make sense? Now, our stresses are different now, right? Our stresses are different. We're all we probably don't think of ourselves as, but we're relatively privileged people, right? We are in a college classroom. Shit could be worse, right? Okay, so our stresses are very different. They are not likely to be immediately life-threatening, but they are going to cause the same stress response. So your stress might be a bad relationship. It might be severe financial problems, right? It could be anxiety. It could be any of those things. And the deal is that your stress response is the same, but the feedback loop is not going to stop unless the stress stops. And so now our stresses, instead of going on for a finite period of time, can go on for decades, right? And I want to see how effective this is at curing the problem when it's an emotional stress. It's really not, is it? But this is our stress wiring. And the nature of stress has only really changed very, very recently, evolutionarily, right? It's been probably within the last 100 years, really? I mean, I don't know, probably within the last 100 years, our stresses have massively changed. And so what's going to happen is with chronic, let's say we've got somebody with PTSD, your cortisol levels are through the freaking roof. Not like just at night, all the time, right? They're a little bit higher all the time. And what's going to happen is you're going to start losing muscle mass and therefore gain weight, right? That makes sense? Anytime you eat, you're going to store it everywhere because you don't trust and you've decreased your metabolism, right? You're going to break down all of the storage in your liver, and you are potentially going to get type 2 diabetes associated with all of that sugar dumping into your bloodstream all the time. And this is sort of the American stress predisposition. They call it metabolic syndrome. That's what they call it. And it's really, really massively exacerbated by stress. And it's not, the problem is that if you were in the 1200s, the negative feedback would eventually fix the problem, right? You'd say, hey, I got over it, right? So I don't need to secrete the cortisol anymore. But if you continue to put in the stress, you are breaking the feedback loop, right? And this is the issue that we are dealing with now. And there's a whole bunch of research into stress physiology. So the stress function, it's involved in adapting the body for stress. This is also required for the synthesis of growth hormone. So now in order to decide to grow, you have to check metabolism as thyroid and then adequate circulating nutrients with cortisol. If you have a problem with either of those, you're going to have a problem with growth hormone. Go ahead. Climate? Emotional climate or climate? Like, it's stressing me out. I don't know what direct impact that has on it. Okay. So last ones here is gonadotropins, and then we can talk about some disorders if we have some time. Okay, so gonadotropins are next here. And the gonadotropins are hormones that are similar to testicular hormones. They're sex-like hormones that don't come from the sex organs. Okay, so they are androgens. Andro means male, so these are male-like hormones. And let me show you what they have to do with the story that I've been telling. Okay, so we've seen this picture multiple times. These collectively right here, guys, are your androgens. These are in higher concentration in males than females, but females have them. If you have testes, you make all four of them. If you don't have testes, you only make these two. DHEA, which is dehydroepiandrosterone. That's the only one I'm not going to make you learn the long name for because I can never remember where all those damn syllables go. And then androstenedione. These are the two that also come from your adrenal cortex, okay? And women only get that far with those two. So the two that you are going to learn are DHEA and androstenedione, okay? So males and females make approximately the same amount of both of those from their adrenal cortex. And these two, please note that one of them can actually get converted into estrogens in different tissues in the body. So what are these for? These androgens that are a weak version of the male sex hormones are largely responsible for sex drive in women. The androgens, guys, the male sex hormones or male-like sex hormones are responsible for sex drive, which is a really interesting thing because this means that there could be a woman who makes both estrogen and progesterone and is totally able to get knocked up and never has a sex drive whatsoever. I would like to talk to the damn management about that. Wouldn't you? Right? You can get knocked up and never even want to have sex. That's screwy. No pun intended. Females have DHEA and androstenedione from the adrenal cortex. Males have DHEA, androstenedione, and the other two. The first two from the adrenal cortex, and then all four from the testes. And so this provides a little inequity in the amount of sex drive, typically, in heterosexual males and heterosexual females. Because if it is androgens that are responsible for sex drive and males have all of that plus a bag of chips, they are going to have generally a much higher sex drive. Does that make sense? And in addition, the testicular androgens have a way higher affinity for receptors than the adrenal cortex androgens. So there is a disproportionate sex drive in males and females, which may seem really annoying when you're married and trying to be monogamous, but if you think historically speaking, we were not monogamous species. Males tended to be relatively poly in their behavior, and females tended to be serial monogamous. So it's evolved for sort of how we evolved, right? And you can be monogamous now if you want to, but it's not your predisposition, and we don't even believe you when you say it is. Okay, so DHEA and androstenedione. So the other thing is that in addition to sex drive, the androgens are responsible for drive. And they're not exclusively responsible for drive, but they really help. So if you have a male with high levels of testosterone, not only does he tend to have a higher sex drive, he tends to have a higher level of aggression or assertion. And what you term that really depends upon context. If you were in prison, you call it aggression. If you were at Harvard, you call it assertion, right? So, and what it does is predisposes both males and females to different behaviors. Females with high levels of androgens also tend to have a pretty high level of sex drive. They also tend to be relatively assertive, which means that you probably call them bitches quite often. But bitches get shit done. And then males, there was a really interesting study that was done. Somebody hypothesized that, okay, testosterone is a really complicated chemical. It's really fascinating. The androgens predispose you to aggression or assertion, and so my hypothesis is that if I go into the prison and assess the testosterone level of people who were incarcerated for violent crimes, I would find a disproportionately high level of testosterone, and then compare them to the population at large. And that's what they did, and they found exactly what they thought they would find. But it was a poor experimental design because they just compared them to the population at large, and then somebody came back and said, well, did you compare them to CEOs? And presidents and athletes? Did you compare them to all of those things? And they did not. And when they figured out that they should go back and redo the study, they also compared the population at large, just any random male, to athletes, CEOs, people in power positions. And yes, if you were in prison for a violent crime, you tend to have a pretty high level of testosterone. But so do CEOs of major companies. So it predisposes you to this sort of drive. And the context of how you are raised and reinforced probably has to do with the manifestation of how the drive occurred, right? So aggression and assertion, I don't know which one. It kind of depends on whether you like the person or not, right? How you actually couch that. Okay, so that's a little bit about testosterone. So in adult females, it's largely responsible for sex drive. If you have more of it, you usually have a higher sex drive. In males, it doesn't seem to have a damn thing to do with sex drive. You could take off the whole adrenal cortex, and the testes make so much of the other androgens that you wouldn't even notice the change in sex drive. So in males, it seems to be really masked by the stronger androgens from elsewhere. Go ahead.
But it's actually interesting because androgens are what's responsible for the hair loss in men.
Yes, exactly.
And Propecia lowers your sex drive, though, which changes the which helps you keep your hair, but it lowers your sex drive and your estrogen. So
isn't that interesting?
Yeah. And it's like the reason too why women don't, because their hair like men.
Yeah, so did you know that baldness, male pattern baldness, it's a genetic predisposition, but it only manifests in levels of high androgens. So ladies, if you really like a manly man, you got to go find a bald one, right? Go look for a bald one, right? He's got a lot of testosterone, but then you might be irritated with him. Did you also know, I'm just going to tell this since I'm almost out of time. Did you also know that females dramatically change what they look for in males depending on whether they are on birth control or not? If you are on prescription birth control that manipulates your hormones, you tend to prefer males with lower levels of testosterone. When you are ovulating, you tend to prefer males with very high levels of testosterone. So I wish I could go back and like redo dating with no birth control and see who I pick. Really, my husband's pretty testosterone-y, but I don't think I want anybody more. Maybe this is better. So yeah, it totally changes who you pick. It changes like what people you find attractive. It changes what scents you find attractive. So it's an interesting like manipulation of your system that you've got going there. So we'll talk about some disorders next time. Oh, quiz on Thursday. I didn't know that about Propecia. Yeah.